Dear doctors, good evening. I'm Pradeep Patni, the CEO of Noveltis. A great pleasure for us here to welcome you today for ADA Konnect, which is organized by our Noveltis division, headed by Altaf. In these unusual new normal times, I trust everyone and their family and friends are healthy and safe. ADA Konnect is an endeavor from our side to ensure that we are able to, in our own small way, contribute towards continuous medical education and learning. A quick word about Noveltis. Doctors, AKUMS is India's largest manufacturing setup, and 12% of all the pharmaceutical tabs, caps, injections, etc., which are sold in India come from our stable. Noveltis is the formulation marketing setup under AKUMS, and we currently span the therapeutic area of gynecology, pediatrics, ortho, dermatology, ENT, and of course, cardiology and diabetology. Quite a few brands of ours were first of their kind, and we take great pride in successfully launching innovative formulations. Going forward, we would want to create initiatives that will make us more relevant and visible in your clinical practice, and we look forward to your advice and suggestions that will help us make our products benefit more and more patients. Thank you so much and have a wonderful evening. Altaf, over to you. Thank you.
Yeah, thank you so much, sir. At the outset, I'm Altaf Qazi here. I take utmost privilege in welcoming all of you to this prestigious and important ADA Konnect initiative. I'm proud to say that here that the objective of Noveltis and our division Noveltis is to promote the notions of continuous learning from amongst endocrinologists and diabetologists. I take utmost pride and privilege to welcome all esteemed faculties and delegate to this important ADA Konnect initiative. I'm indeed very thankful to Dr. Shehla Shaikh, Dr. Rajeev Chawla, Dr. Subhankar Chowdhury for so nicely summarizing day 1, 2, and 3 proceedings respectively from ADA through short videos, keeping in mind the busy schedule of endocrinologists and diabetologists in India. This special wrap-up session is a culmination of those daily updates. And to do so, let me welcome Dr. Subhankar Chowdhury from Kolkata for this ADA Konnect initiative. Dr. Subhankar Chowdhury is a professor and head Department of Endocrinology, IPGMER and SSKM Hospital, Kolkata. He has held several official positions: member subject expert committee, CDSCO, Government of India, founder patron, South Asian Federation of Endocrinology Societies. He has been immediate past editor-in-chief for Individual of Endocrinology and Metabolism, past president for Endocrinology Society of Bengal, and past president for Endocrinology Society of India. He has current research interest in gut microbiome and gestational diabetes mellitus, pathogenesis of Graves' orbitopathy, biology of fat in different body compartments, and he has got over more than 201 publication peer review journals. I would also welcome Dr. Rajeev Chawla, who is a senior diabetologist director, Delhi Diabetes Center from Delhi. He has been an honorary professor for Jaipur National University, visiting professor at Jailan Medical College and Kelly Academy of Higher Education at Belgavi, that is Karnataka. He has been a teacher for more than 20 years, more than 80 papers on micro and microvascular complications, awarded AAC Travel Day grant twice for masterclass paper. He has authored 10 books on diabetes. He has been past chairman for RSADA Delhi chapter. He has been past secretary for RSA national body. He has held several important scientific chairs in RSA 2018. He has been executive editor, International Journal of Diabetes in Developing Countries. He has been president of DIPSI 2019, and he has been immediate past president RSDI. Now, I would also welcome Dr. Shehla Shaikh. She is an endocrinologist from Saifi Hospital, Mumbai, who works with Saifi Hospital, Wokhad Hospital, and Prince Ali Khan Hospital. Principal investigator in as many as more than 34 clinical trials internationally. She has been member of executive committee of ESI Diabetes India. She has been a treasurer ESI Maharashtra, member of scientific committee for CAD, has been awarded top doctors award by Times of India Group from 2017 to 2020, and she has been author of International Hajj and Diabetes Guidance and IDFR DAR Guidelines 2021. She has published many papers, review articles, and speaker at national and international forums. We also have Dr. John Buse, who has joined us from North Carolina, USA. Welcome, Dr. Buse. Dr. Buse has been the one Cabinet's Distinguished Professor, Chief of the Division of Endocrinology, Director of Diabetes, Director of the NC Transnational and Clinical Sciences Institute, and Senior Associate Dean for Clinical Research at the University of Carolina, School of Medicine in Chapel Hill, North Carolina. Dr. Buse completed service as President for Medicine and Science at the American Diabetes Association in 2008 and as Chair of the National Diabetes Education in 2014. Dr. Buse has received numerous awards and honors, including the 2010 Castle Connolly National Physician of the Year Award and the 2019 American Diabetes Association Outstanding Achievement in Clinical Diabetes Research Award. Dr. Buse has authored more than 4,000 publications. May I now request Dr. Subhankar Chowdhury to take over the proceedings of ADA Konnect program from here and set the tone for this program.
Very good evening to our Indian colleagues, and it's a wonderful opportunity to have such an wonderful person as John Buse to take us through maybe the capsule of what happened in this year's ADA. We do know since last year we are having virtual sessions of ADA. And I don't know, of course, it's no longer John Buse's worry maybe, but at one time he was president of the scientific section of ADA, whether people will now prefer to go to virtual mode rather than have a physical meeting in future. Let's see what happens. Now, what we'll try and do is have Dr. John Buse, his take on the important presentations over the 3 days. And then, of course, we can try and interact with him and amongst ourselves. I hope that's okay. If so, yeah, Shehla and Rajeev, yeah. And then over to you, John, to take us through ADA 2021.
Well, thank you very much. It's really a pleasure to share the stage with the sponsors and you, Dr. Chowdhury, Dr. Chawla, Dr. Shaikh. You know, you raised a great question about whether these formerly face-to-face meetings will return to face-to-face meetings. I do think people like the personal interaction, but I have to say, as a mode of spreading medical education, it's hard to beat the Zoom call. So I'll do my best. Let me share my screen. Let's see. Is that looking right?
Yeah, absolutely fine. And you're heard well as well.
Perfect. So what I'm going to do is show 1 to 5 or 6 slides on each of almost a dozen studies that were presented. I would tell you, though, that there were 5 days of presentations, probably about 30 symposia and several hundred abstracts. There's probably 150 hours of content. So if you talk to 10 different people, you'll get 10 different sets of really important research that was presented. If you really love diabetes, I would think about registering. You know, over the next few months, you could do 2 hours a day and still have room to run in finding out things that were discussed at the ADA meeting. So first, I'd like to talk about F-beglanitide. So this is another GLP-1 receptor agonist that has not been marketed yet in any country. It was being developed by Sanofi and a small company called Hamni. Sanofi returned the rights to Hamni, so it's a little bit unclear what the path forward is for F-beglanitide. but it seems quite a nice drug. This is the Amplitude M study. So as a reminder, F-beglanitide is an exendin-4 based molecule. So in the same family as exenatide and lixisenatide, but different from all the others, which are based on the human GLP-1 receptor, GLP-1 molecule. It's been fused to a non-glycosylated FC antibody molecule, and that has decreased the renal clearance and decreased the endothelial clearance. So the half-life is about 7 days. It's suitable for once weekly dosing. The phase 2 program suggested efficacy, and the phase 3 program studied 2, 4, and 6 milligrams weekly here as monotherapy. So many slides were presented. I'm just going to hit the highlights. As far as the proportion of patients that achieved a hemoglobin A1C less than 7%, very good, about 74% at the highest dose compared to 25% with placebo. Hemoglobin A1C less than 6.5%, you know, almost surprisingly good at nearly 60% of patients at F-beglanitide 6 milligrams versus 9% with placebo. With regards to weight loss, focusing more on the right, 3 kilogram or so weight loss from baseline at the 4 and 6 milligram dose, that being approximately 2 kilograms average by least square mean difference, different from placebo. So nice weight loss as well. I would point out that the curve for the higher doses, you know, one of them suggested at 30 weeks, the weight loss is flattened out. The other one suggests that the weight loss persists. I do think in these 30-week studies, sometimes we don't see the full effect of the drug, remembering that the titration phase takes 12 to 16 weeks to get to the highest dose. With regards to GI side effects, you know, this is pretty much on par with the other GLP-1 receptor agonist programs, maybe a little bit more diarrhea than we're used to seeing, but I think otherwise about the same. We have to be careful in overinterpreting that because, to be honest, the results that you get depend on exactly how you ask the question. So I'm not sure there's really a difference in the GI adverse event profile. As you would expect in a program where without background medications, very low rates of hypoglycemia, and you know, only one episode of severe hypoglycemia, the details of which were not discussed. So in conclusion, they point out that this Amplitude M trial, the first F-beglanitide phase 3 trial, demonstrated significant benefit versus placebo after 30 weeks, and that was sustained at 56 weeks. More people achieving A1C targets, significantly greater weight loss, and safety and tolerability consistent with the class. The second presentation, this was very nice. Again, you know, my apologies, I'm presenting 3 or 4 slides out of what was a 30-slide presentation. So this is presented by Carolyn Lam from Singapore on the DAPA heart failure and Emperor Reduce trials. And she asked or answers the question, do we have all the answers for SGLT2 inhibitors in heart failure with reduced ejection fraction? And she pointed out some interesting additional analyses. So of course, in these heart failure outcome trials from the SGLT2 inhibitor class, you know, very strong evidence for benefits on heart failure hospitalization, cardiovascular mortality, kidney function, and beyond. Here, she looked at the effect as a function of age. So in the 4 panels on the left, less than 55, 55 to 64, 65 to 74, and greater than 75. And I think you can see pretty evidently that, it seems to be consistent across age groups that there's a benefit. On the right, a bit more of a sophisticated analysis. So looking at the hazard ratio on the y-axis and age on the x-axis, and in the 4 panels, primary outcomes. So that's heart failure, hospitalization, or cardiovascular death, and then cardiovascular death, and then heart failure, hospitalization, or urgent visit, and then all-cause death. And what you see by the shape of the curve, again, pretty flat. So older patients, younger patients, it doesn't matter. It's about the background condition of heart failure with reduced ejection fraction, and consistently across the board, dapagliflozin demonstrated benefits here. In the Emperor reduced, just a reprisal that the summary would be a 25% reduction in the composite of cardiovascular death or heart failure hospitalization, a 30% reduction in first and recurrent heart failure hospitalizations, and a 50% reduction in renal events. And then finally, a slide that just sort of summarizes that whether in the Emperor reduced study with empagliflozin or the DAPA heart failure study with dapagliflozin, in the setting of reduced ejection fraction, if you look at adjudicated cardiovascular death or hospitalized heart failure, time to first event, the absolute risk reduction is pretty similar. The number needed to treat, pretty similar, around 20 over 16 to 18 months. So great consistency across 2 completely separate clinical trials, giving us tremendous confidence that using SGLT2 inhibitors in the setting of heart failure with reduced ejection fraction is associated with clinically very meaningful events. And then secondly, below that, the number needed to treat for comparable durations across the trial, very similar as well. So continuing on the theme of landmark trials involving SGLT2 inhibitors, David Wheeler from University College in London talked about the DAPA-CKD study and extending the benefits of SGLT2 inhibitors to and beyond diabetic nephropathy. He did a bit of a contrast of the Credence trial, which was the kidney outcome trial for canagliflozin, and then the DAPA-CKD trial, the kidney outcome trial for dapagliflozin. Did I say that wrong? Credence was with canagliflozin, DAPA-CKD with dapagliflozin. So the target population in Credence was exclusively patients with type 2 diabetes and chronic kidney disease. The DAPA-CKD study was chronic kidney disease, but either with or without type 2 diabetes. Now, they did specifically exclude type 1 diabetes. In Credence, the eGFR criteria was 30 to 90. In DAPA-CKD, a bit lower, 25 to 75. In Credence, needed 300 to 5,000 milligrams per gram albuminuria for inclusion. In DAPA-CKD, extends the range a bit lower, down to 200. People could have had prior cardiovascular events. They didn't have to. They did not include people on renal replacement therapy. They did not include patients with type 1 diabetes or stage 4 heart failure. And in Credence, everybody had to be on an ACE inhibitor, but they could be on a very small dose. In DAPA-CKD, it was essential unless contraindicated. So if you look at the primary and secondary outcomes in the DAPA-CKD study, and the primary report was published late in 2020, you see for the primary outcome, kidney, which was a composite of kidney and cardiovascular disease, particularly mortality, you see a hazard ratio of 0.61, so huge benefit. For the kidney-specific outcomes, a sustained greater than 50% reduction in eGFR, the development of end-stage kidney disease defined as an eGFR less than 15 or renal death, hazard ratio of 0.56, so a 44% reduction in risk, huge benefit for cardiovascular death or heart failure hospitalization, hazard ratio 0.71, for all-cause mortality, hazard ratio 0.69. Really, outstanding performance for a drug, changing clinically meaningful outcomes. When looking at the primary and secondary outcomes by diabetes status, as opposed to going through all the numbers for you, I just point out on the right, the p-value for interaction is not significant. So whether patients have diabetes, type 2 diabetes or not, the outcomes that I just reviewed for you are very similar. With regards to specific other chronic kidney disease etiologies, and so for each of the 4 outcomes, as you go from top to bottom, you see diabetic nephropathy, ischemic or hypertensive chronic kidney disease, glomerulopathies, or other or unknown forms of kidney disease. Again, to the far right, when you look at the p-value of the interaction term, none of them showing any trend towards significance. When you look at the individual details, some are, jumping around a bit. But remember, if you look at in the numeric columns to the left, some of these have very few events. So, for instance, for cardiovascular death or heart failure, in the glomerulonephropathies, we have 3 events versus 7 events. So there's, substantial uncertainty in those very wide confidence intervals. But overall, doesn't matter what kind of kidney disease. So in conclusion, he pointed out that DAPA-CKD shows that in patients with chronic kidney disease with or without type 2 diabetes, dapagliflozin compared to placebo reduces the risk of kidney failure, reduces the risk for death from cardiovascular causes or hospitalization for heart failure, prolongs survival, and was consistent across all the patient subgroups examined with or without type 2 diabetes, different chronic kidney disease etiologies, different chronic kidney disease stages, and those with and without prior cardiovascular events. So again, we have tremendous confidence now that SGLT2 inhibitors provide clinically meaningful and impressive benefits in the setting of chronic kidney disease, with and without diabetes. And then a really beautiful set of studies, the STEP studies, the semaglutide at higher doses for the indication of obesity, not diabetes. And again, I apologize, this was an outstanding presentation from Dr. Kushner, examining multiple endpoints. I'm just going to pick some highlights here. So we reviewed the 4 pivotal trials. So again, step 1 was on a background of sort of standard lifestyle intervention, semaglutide versus placebo. Step 2, again, on the background of standard lifestyle intervention, looked at semaglutide 1 milligram, the currently approved dose for type 2 diabetes management versus 2.4, the new dose for weight management versus placebo, matched placebo, over 68 weeks in the setting of type 2 diabetes. So this is weight management in the setting of type 2 diabetes, not glucose management in the setting of type 2 diabetes. And then my favorite trial, the step 3 trial, looked in the setting of intensive behavioral therapy. So this combined both meal replacement therapy for the first 8 weeks and semaglutide versus matched placebo, followed by ongoing intensive behavioral therapy for 68 weeks. So semaglutide plus intensive behavioral therapy versus placebo plus intensive behavioral therapy. And then the step 4 program looked at the sustained weight management. So run in semaglutide and then randomizing people to semaglutide or placebo. The studies looked at the same endpoints pretty much across the board. To summarize all the results, in general, the weight loss was spectacular, up to around 15% loss of body weight. In the step 3 program, where it was combined with intensive behavioral therapy, and when I mean intensive, I'm talking about really intensive behavioral therapy with powdered meal replacements, the whole 9 yards, that made about a 1% difference. So what it really suggested to me is that this is a powerful drug on enhancing satiety, reducing appetite, reducing food intake. And so it turns out that even the most powerful behavioral therapy interventions don't really add much. Now, it's not that intensive behavioral therapy doesn't work, because they achieved about a 8% or so loss in body weight. So a very nice response to intensive behavioral therapy. It's just intensive behavioral therapy plus high dose semaglutide therapy doesn't make a big additional benefit because of the powerful effect on appetite, which is really the driver for weight loss. And just to point out that the benefits extended beyond blood pressure, beyond glucose to blood pressure and other markers. I don't have time to go through it all, but a very strong performance of high dose semaglutide in the setting of overweight and obesity to reduce clinically meaningful biomarkers. So the summary is produce mean weight loss in the range of 15 to 70% in those without type 2 diabetes, and has been seen with essentially every drug development program in type 2 diabetes, somewhat diminished weight loss, but still an average 10% weight loss in the setting of type 2 diabetes. And then if you look at greater than 5% weight loss or greater than 10%, the benefits of semaglutide hold true across the range, and the safety profile consistent with what we know about the GLP-1 receptor agonist class. So I participated in this symposium where Luisa Caramori presented the KDIGO 2020 Clinical Practice Guideline in Diabetes Management, CKD. And my role was to present the American Diabetes Association Standards of Care and the ADA ESD guidance. And what I would say is KDIGO is much better. It's not different. The advice isn't really different, but because they deliver the advice over about 50 pages compared to the 10 pages for the ADA, there's just a lot more detail. So they recommend that RAS blockers be used in patients with diabetes, hypertension, and albuminuria, and that they should be titrated to the highest approved dose that's tolerated. They recommend more intensive glycemic management in patients with less advanced disease, and thinking about more easily achieved levels of glycemic control, perhaps as high as less than 8% in people with more advanced disease, with other difficulties like impaired hypoglycemic awareness or lower life expectancy. But in general, this is highly aligned with the American Diabetes Association. They recommend vigorous physical activity in patients with chronic kidney disease, and point out that though this sometimes can increase albuminuria transiently, there's no evidence that it is associated with any worse outcomes. And in fact, there is evidence to the contrary, that moderate activity consistently delivered at least 150 minutes per week is associated with benefits. Their algorithm is very straightforward. Lifestyle therapy for everyone, physical activity, nutrition, weight loss. If patients have chronic kidney disease, they should get metformin and SGLT2 inhibitors. If their EGFR is less than 30, you would discontinue the metformin. If they're on dialysis, you wouldn't use metformin. If the EGFR is less than 30, you wouldn't initiate an SGLT2 inhibitor. I do think that this might change in the future based on the more recent trial results that we just reviewed. And then if that doesn't work, an assortment of other drugs can be delivered. They strongly recommend using an SGLT2 inhibitor in patients with type 2 diabetes and chronic kidney disease if the EGFR is greater than 30, and that to prioritize the use of agents with a documented kidney outcome trial in particular. And though you may see a little decline in EGFR, stay the course, the benefits will come. and that if the EGFR goes below 30, you would continue with the SGLT2 inhibitors. The GLP-1 receptor agonists are an alternative for those who would not tolerate or are unable to use the SGLT2 inhibitors in the setting of chronic kidney disease, and not to use them in combination with a DPP-4 inhibitor. So the guidelines, the KDIGO guidelines provide, are very broad, focused on patients with chronic kidney disease, and they are beautifully presented. They are patient-centered. They focus on lifestyle and hemoglobin A1C and drug therapy, and about the coordinated effort that's required to broadly address the needs of the chronic kidney disease population. Then Credence, the other SGLT2 inhibitor renal trial, Brendan Nguyen from the George Institute presented subgroup analyses from the trial. He pointed out that Credence and DAPA-CKD is a very different population from what's been done before. So substantially more albuminuria and substantially lower EGFR than had been seen in the cardiovascular outcome trials or the heart failure trials, and more like the chronic kidney disease trials of the renin-angiotensin system blockade programs. So this just points out the point estimates of the hazard ratio for the outcome of kidney failure in EMPA-REG, CANVAS, and DECLARE, the cardiovascular outcome trials, versus the Credence trial, and points out that overall great consistency, but because the trial focused in patients with chronic kidney disease, the confidence intervals are much narrower. So the result was kind of predictable, but now we have great confidence in the result. And then pointed out, bridging back to the last presentation, that this is why the KDIGO guidelines so strongly recommend the use of SGLT2 inhibitors in this setting. They further pointed out that if you look at patients with resistant hypertension, that it provided for blood pressure lowering, whether people were on 0 or 1, 2, or 3 different blood pressure classes. But in the bottom, whether you talk about the primary outcome, the renal outcome, MACE events, heart failure, or cardiovascular death, the proportion of the benefit that's explained from blood pressure lowering is quite low. So it's not because these drugs lower blood pressure that they prevent the progression of chronic kidney disease or these other endpoints. It's something that goes beyond that. And then also pointed out that beyond the effect to reduce the progression of chronic kidney disease, we've known for a while that SGLT2 inhibitors are associated with a rise in hemoglobin and hematocrit. Here they point out that the SGLT2 inhibitor Dapagliflozin in the Credence trial was associated with a reduced risk for the diagnosis or anemia and initiation of treatment, and on the right, reduced risk of requiring or initiating erythropoietin stimulating agents with a hazard ratio of 0.65 for both. So another ancillary benefit. So I think we're kind of beating a dead horse here, or not dead horse, a very vigorous horse, but we've made the point several times, so I'm not going to repeat all the bullet points here. But SGLT2 inhibitors are really magical drugs in patients with chronic kidney disease, particularly with advanced albuminuria. And then I think this is the last of the SGLT2 inhibitor trials that I'll present. I'm not going to present a lot of the results, again, because I just don't have time, but I think the implications of the DARE-19 trial are very important for the COVID pandemic, including with the ongoing problems in India. So DARE-19 was a trial of SGLT2 inhibitor versus placebo in patients hospitalized with an acute infectious illness, COVID. That has never been done before. The important result is that Dapagliflozin was very well tolerated. No new safety issues were identified. In the whole trial, there was only one episode of DKA. So the concerns about using SGLT2 inhibitors, particularly in the hospital, particularly in the setting of acute illness like COVID-19, those concerns are not supported by this trial, at least in the hospital. And you know, the hospital is a place where people are being monitored very carefully. In that kind of setting, you could consider continuing to use the SGLT2 inhibitor, but remember that the labeling of the drug would be generally to discontinue it before surgery or other periods of fasting in preparation for procedures. There wasn't a direct benefit, but a trend towards benefit in COVID, in severe COVID-19 outcomes. Okay. So then, you know, the last bullet point here, the results of the DARE-19 again highlight the value of challenging conventional wisdom by demonstrating the safety of dapagliflozin in patients hospitalized with acute illness in the context of a trial where people are focusing on safety. There are other studies that show when you're not really focusing on the SGLT2 inhibitor, bad stuff happens on occasion. So I think the current labeling is still recommended. Here's a paper from Deepak Bhatt, one of a couple presentations at the ADA looking at additional analyses on the icosapent ethyl product, basically fish oil derivative, and the effect of BMI or diabetes status on the cardiovascular risk reduction there. As a reminder, the REDUCE-IT trial randomized patients to icosapent ethyl 4 grams a day versus matched placebo. The placebo was mineral oil, and these are patients that were on statins with established cardiovascular disease, or they could come in with diabetes and at least one risk factor. The triglyceride range for eligibility is 150 to 500, and patients were follow up for an average of, well, it was up to 6.2 years. So first, what they show here, previously disclosed are the sort of lightened out results. So that was the time to first event. The bolder results is the time as the total first and subsequent events. And what you can see, if you can include all the events beyond first events, the hazard ratio stays very much the same or gets better. On the left, for the primary composite endpoint of heart attack, stroke, cardiovascular death, and on the left, categorized by BMI. So BMI less than 25, in the middle, BMI 25 to 30, and on the right, BMI greater than 30. So again, across the board, very little difference in the hazard ratio. Here, subgroup analyses, again, stratified by baseline BMI in the population with diabetes, no interaction. At the bottom, people without diabetes, no evidence of interaction. So consistently, diabetes, no diabetes, BMI elevated or BMI normal, no difference. So in conclusion, icosapent ethyl 4 grams a day significantly reduced first and total primary endpoints consistently across BMI groups with or without diabetes. And then a very interesting symposia. So 2 hours of material. This is one of, I think it was 3, maybe 4 speakers that looked into the issue of transplantation in diabetes. Here, the focus is on pancreas transplantation. I will touch on islet transplantation. First, he points out that the number of people that are being listed in the United States, waitlisted for a pancreas transplant, has been declining. He speculates that this decline is related to more treatment options in the form of pumps and hybrid closed loop and sensors, and that complications are developing at later ages where transplantation may be viewed as higher risk. The diabetes technology, though it addresses a lot of the issues, we're still left with patients that are not able to achieve normal glycemia. There there is some additional burden in the disease, and patients with severe beta cell deficiency, trying to approach these intensive targets with a machine with insulin does put people at some risk of excess risk of hypoglycemia. So he points out that if you do solitary pancreas, if you do a pancreas transplant, simultaneous pancreas kidney transplant, in the dashed line at the top, after about 10 years as compared to living donor kidney transplant, or in the bottom line, deceased donor kidney transplant. So, between 5 and 10 years, the simultaneous pancreas kidney transplant is associated with survival benefit in epidemiologic studies. So not in a formally randomized trial. And pointed out that if you did have patients who had evidence of severe beta cell failure, and perhaps the strongest evidence is patients that are having recurrent problems with hypoglycemia, or where you just cannot deliver insulin in a way that controls the glycemia, first you should look to other options than transplant to improve glycemic control, like pumps and sensors and closed loop systems. Sometimes even when that works to improve glycemic control, you may need to still think about transplant. And if there are factors that are unfavorable for whole pancreas transplantation, a more major surgery, you might want to think of islet transplantation alone. If there are not issues that would preclude whole pancreas transplantation, again, you may want to you do need to talk it over with patients about their goals and expectations and their level of risk aversion as whether to proceed with transplantation at all, and particularly whether pancreas transplantation versus islet transplantation. He points out that there are not dramatic improvements in quality of life. There are improvements in quality of life, but when you look at it overall, no major changes in psychological symptom scores, and that just needs to be taken into account to manage expectation. And then finally, that pancreas transplant is a good treatment option in a very severe subgroup, even in the setting of advances in diabetes technology, that islet transplantation and pancreas transplantation require teams of people and very specific patient counseling factors, but that these centers are available. And then I think this may be the last one. Vera Novak presented a very interesting study. This hypothesis has been going on for a long time that intranasal insulin might provide for very special benefits. So she points out that diabetes accelerates brain aging by about 5 years, and that you have brain insulin resistance as manifested by cognitive decline and slow walking, about 10 centimeters per second being the threshold, and that this slow walking is associated with increased mortality. And then she points out that intranasal insulin can improve visuospatial and verbal memory. It seems to enhance insulin signaling in the brain and perhaps functional connectivity. And maybe the benefit is really related to increased blood flow and brain energy metabolism. So without a marked systemic effect, a local effect in the brain that may provide for neuroprotection. So these people were people who overall had very, very early kind of cognitive decline. People with more advanced disease were not included. They got 24 weeks of treatment of 40 units of intranasal human insulin versus placebo once a day, and then 24-week follow-up with a variety of different measures. And what you see here is, if you look at the MRI sub-study, clearly an effect to change cerebral blood flow in most of the patients, an increase in cerebral blood flow Not shown here was some of the other endpoints on walking times and cognition, that there was imbalance between the groups, and so a little bit of lack of clarity how much of an impact on those other markers. But the bottom line from this is that there was some faster walking speed, there was increased intracerebral blood flow, and reduced insulin resistance in the patients treated with intranasal insulin. It seemed to show improvement in executive functioning and verbal memory in particular, and that though these things overall did not reach statistical significance, they certainly showed trends, and that further and it demonstrated safety of the approach, and that further study of this perhaps novel and very likely safe approach to cognitive decline, which is a huge problem in America, is worthwhile. So with
Thank
that,
you. Yeah.
I'll end the presentation.
Yeah, sure. Sure. You can stop sharing the screen. Yeah, that was wonderful. And as in previous years as well, we have such a wealth of information coming out of the ADA. And this year, interestingly, they were also re-look at already published studies and interesting sort of conclusions drawn out of it. So if you take the last one, the intranasal insulin, lest we forget that because of cognitive decline, if we are addressing insulin resistance, wouldn't it be more logical to use an insulin sensitizer rather than insulin itself?
Yeah, I think I'll sort of back up for a second. This has become a very popular area in drug development. So big scandal in the United States about a Alzheimer's disease drug that failed both of their phase 3 programs, but still got FDA approval. Active development programs for virtually every class of drugs in diabetes to see whether it slows cognitive decline. So you can clearly make an argument for using GLP-1 receptor agonists, SGLT2 inhibitors, metformin, TZDs. Insulin is a little bit tougher, right? Because insulin therapy is associated with hypoglycemia. We do have data from Accord and the Origin trial. So I think the nice thing about this program is that when you put insulin up the nose, perhaps it does deliver it more directly to the brain. I think it's an interesting hypothesis, but if you saw the whole presentation, the level of evidence that it's good is pretty thin in a small study. And so, I do think it's going to take a major development program, and whether someone is willing to take that risk and move forward with it will be of interest.
Right.
May I say something here? In continuation, what you really raised a very valid point. And Dr. John Buse, before I say anything, I must congratulate him for a wonderful capsule which he has rolled out. I think he has summed up all 4 days important clinical trials and given very good carry-home messages out of each trial. Now, coming back to this trial, which is with intranasal insulin, I think, as he rightly said, we have used all sensitizers like GLP-1 analog or SGLT2 or typical sensitizers like metformin and TZs, but none of the sensitizers have actually helped in reducing or in improving either the cognitive decline or in patients those who have presenile dementia or maybe something like Alzheimer, what we commonly label it as type 3 diabetes. I think it is for the first time that an intranasal insulin, which we shouldn't compare with the systemic use of insulin, subcutaneous or IV, it's an intranasal insulin which is directly going into, and what has been proven with even with these live MRIs or dynamic types of MRIs, not only have improved conduction velocities and improved insulin resistance. So I think this should be seen as absolutely apart from any other sensitizer which we use in practice of diabetes or even in non-diabetic person. An intranasal spray getting directly into the brains on the receptor may be working differently.
Yeah, and of course, we need to have a lot more data. I mean, as was the conclusion from the study, absolutely. Coming back to the first one, the epiglenatide. So can I ask Shehla, I mean, do you see there is scope for more and more GLP-1 receptor agonists to come into the field? Of course, we have so many sulfonylureas, so many DPP-4 inhibitors, SGLT2 inhibitors. Shehla, and then I'll come back to you, John. I'll come back to you, John. Yeah, Shehla.
Sir, I think at this point of time, if we are able to increase the usage of the present GLP-1 receptor agonists only, that will be great. In the sense we already have plenty in the market, but we're still not able to use it as well as we should be using it. The outreach, I mean, all the guidelines say that we should be using it up there, but we're still not using it. So I'm not really sure, unless something, they give you some really great benefit, like maybe once a monthly injection or something like that, then I think, yes, but otherwise,
But don't you think that a GLP-1 analog for the first time demonstrating a weight reduction almost up to 6 kg is very, very unusual. Neither with the liraglutide or even with semaglutide, we haven't seen actually more than 6 kg weight loss happening, that too with once a week therapy. So that way, this molecule could be an edge over other GLP-1 analog, that weight loss is very, very significant with a once week therapy.
Of course, we are not sure whether this will go on to further phases of development. Sanofi having sort of let go of this molecule. So John, this is for you. John, can I? Yeah.
Well, let me just add to that discussion. So one of the presentations that I didn't review was published in the New England Journal of Medicine, which is the cardiovascular outcome trial that was done. Now, because the financial plug was pulled, they didn't complete the trial. But I'm just looking at it. It's the hazard ratio was 0.73. So I think that is the reason why that drug might get resurrected, because the outcome in the cardiovascular outcome trial was so powerful.
Yeah, absolutely. So that's a related question, John. Does the ADA, or for that matter, other professional bodies, do they or should they sort of counsel the industry as to what are the real felt needs, and then hope that they invest in development in those directions? Does that talk happen with the industry?
Yes, I think the talk happens from regulators like the Food and Drug Administration. The talk happens from customers, from patients, from doctors. Everybody is giving their opinion to the pharmaceutical industry. But until we change, the reimbursement method, I don't think the industry is likely to change what they do, no matter what people say. At the end of the day, they are a business. And I do think that the third and the fourth and the fifth drug in a class, it costs the same $1 billion to develop the drug. And then you take whatever benefit a company was going to get from a drug, and now you divide it among 6 different companies. There's relative less benefit for the same cost. But as Dr. Chawla pointed out, the new drug development in this space is providing for better, in some ways, better outcomes. So it's a tough decision. Exenatide, twice a day, great drug, the innovator, #1 to the market. That said, they are easier to use agents that have been associated with greater benefits. And the question, is the world a better place for having these advances, or is it great that we have, relatively inexpensive, well-tested exenatide twice a day? It's a debatable question.
Absolutely. And a quick one, when you use a GLP-1, maybe Shehla, do you monitor calcitonin levels? even John, do you need to do that? I wouldn't. I do not.
We don't do it, sir.
trial. Yeah. So is it done there, John? Do you
No,
monitor in clinical
no.
use?
No, in the clinical trials we do,
No,
because
yeah,
the
yeah, that's I
regulators
know.
want us
Yeah,
to.
yeah.
But in clinical use, I have never measured a calcitonin level
Yeah.
in my life.
Yeah. So I mean, right now I'm part of the SOUL study, the oral semaglutide study. So this has been going on. I mean, the point I wanted to make was I somehow don't feel that there's a major issue with calcitonin or medullary C-cell hyperplasia or in human beings. Now, we have had a lot of talk about SGLT2 inhibitors, and it's great to understand, to know once again that the benefits seen with DAPA and EMPA are sort of it's reinforced that you do get the benefits across, and both from the kidney protection point of view, from the heart protection point of view, and the recent sort of approvals for their usage at lower GFRs. We need, of course, to understand that these are not for better HbA1c achievement. When we're using at lower and lower GFRs, we should not expect further A1c improvement. Of course, we are using it for organ protection. So that's something we need to take an important clinical lesson, I mean, for us practitioners across our country. And any other issues or questions someone else would like to bring up? Yes, Dr. Chawla.
SEMA SOUL, I am also part of that study. And coming back to step trial 1, 2, 3, and 4, Dr. Buse, you said that in non-diabetic person, you had a weight loss close to 17%, while in type 2 diabetes patient, even with the standard care, the weight loss was only 10%, while we know that GLP response is blunted in type 2, but in no way, if you increase supraphysiologically the levels of GLP-1, you get an identical benefits, whether it is diabetic or non-diabetic. So how do you explain the difference of 7% weight loss more so in non-diabetics, but not in diabetics?
Yeah, you know, it's a question that we talk about all the time. And so I used to think that part of it was related to the background of metformin therapy, that metformin does increase GLP-1 levels a bit to start with, so that when you add a GLP-1 receptor agonist in the setting of someone whose GLP-1 levels are already a little bit higher, that maybe you don't get the full benefit. But that's not the answer. And the reason I say that is, you know, if you look at the locus-cerin clinical trial program, or the Phentermine clinical trial program, or behavioral weight loss therapy, it doesn't matter what therapy you use, you always get less weight loss with the same therapy in people with diabetes than you get in people without diabetes. And I don't know if it's just telling us something about that, you know, that people with diabetes are sort of just tougher cases with regards to weight. I mean, part of the reason why they got diabetes is because they have some kind of drive towards weight gain. So I don't think it's something special about GLP-1 as a probe. I think it's that people with diabetes are special with regards to the challenges.
Is it just down regulation of receptors in type 2 versus non-diabetics?
Not GLP-1 receptor. I mean, maybe it's some other brain receptor. But I mean, my guess is it's a real biologic difference, because we see it over and over and over again. I just don't know what that difference is.
We have a lot of questions coming into the chat box. I don't think we'll be able to do justice to all of them, but maybe some we should take. And one is for Dr. Buse as to how do you compare DAPA, EMPA, and GANA?
Right. I mean, I think in general, the SGLT2 inhibitors and the DPP4 inhibitors as classes were designed to do what they do, a very specific medicinal chemistry. So they tend to behave pretty much as a class. There's not huge distinguishing factors. If you try to sort out some distinguishing factors, you know, some people worry about canagliflozin and amputations. You know, the black box warning has been taken out in the United States. You know, I do think it's worth talking about with patients who have very high risk neuropathy or prior foot ulcers. But other than that, you know, it's whichever one you can get. Right. Taking an SGLT2 inhibitor is more important than which one you take.
Right. And there's a question from Dr. S.L. Ismail. SGLT2 inhibitor is safe in type 1 diabetes?
That's a big question. I'd say the short answer, it can be used, but you have to be very, very careful. There's clearly about a 4%, you know, 1 in 25% increased risk of diabetic ketoacidosis. In the empagliflozin development program, there was a young 26-year-old woman who died of diabetic ketoacidosis and during therapy with a SGLT2 inhibitor. That clearly would not have happened without the empagliflozin, because it was euglycemic diabetic ketoacidosis, and the doctors that were treating her got confused. So I think you have to be very, very careful. There are benefits, but there are clear risks, including death. So, you know, got to think twice before you do that.
There's some data by Dandona's Center on DAPA in type 1 as an adjuvant therapy. They have shown that even UDK was not very high as long as you are, I mean, little pharmacovigilant and following those patients.
Yeah. So until someone dies, what I'm saying is you can be really, really careful.
Yeah.
And then someone might die. And I just think, you know, it's the problem with type 1 diabetes. If you do a decent job, people live a long, long time. They live a very good life. And so I do think you have to be very cautious with this drug, because in, I don't know, a few thousand people, one died, clearly as a consequence of the drug. So I do use SGLT2 inhibitors in patients with type 1 diabetes, but not in everyone. In very safe, carefully selected patients. And I talk to them at every visit about checking their urine ketones. They don't check it every day, but anytime they don't feel 100%, being aware of what to do if they have ketones in their urine, because it's counterintuitive. It doesn't matter what your blood sugar is. You have to eat carbohydrates. You have to take insulin. Insulin is the antidote for ketoacidosis. So it's a complicated business. It shouldn't be taken trivially.
But in which type 1 would you actually consider using it, with BMI being more?
Yeah, so I think the two settings would be, you know, mostly in patients with heart failure and chronic kidney disease. I think there you really start thinking, you know, there's a huge potential benefit. So we're willing to take a substantial risk. There are some patients who struggle with glycemic control and weight, where, you know, they're starting to screw around with their insulin dose. You know, they're taking less insulin and hoping that it helps them manage their weight, where I've thought about that. But again, it's all about patient selection and counseling. You want a very careful patient, you know, who's very cautious in their self-care behaviors.
Right. I think we have crossed our time, actually, and it's been a wonderful evening having.
Can we have a last comment from Dr. Buse on reduce IT BMI? It's an interesting trial where we all know it's a omega-3 fatty acid derivative, primarily icosapent-ethyl. Earlier trials have never demonstrated reduction in CV outcomes except the improve, which was ezetimibe, by reducing triglyceride. So how do we explain significant 31% reduction in outcomes with a drug which is primarily reducing TGs, Dr. Buse?
Yeah, this has been hotly debated, and I'm going to give you a sort of non-answer. So one of the hypotheses has been put out there is that this trial compared versus mineral oil, and that the other trials compared against olive oil, or, you know, other kinds of oils, corn oil. and that maybe it's something special about mineral oil being not good that caused the difference. Now, that said, there are a number of publications since then that, this is highly purified mineral oil. We don't really expect things. It's been used as placebo before. Great record of safety, blah, 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 blah. The truth of the matter is all these questions, Dr. Chawla, you always raise these great questions. They're questions we don't have answers to, but there are areas of speculation. Now, that said, I do think that everybody believes that fish oil should be good for your heart. Maybe it's not good for your heart, but it should be. And so one day I'll figure out why fish oil, how to use fish oil in a way that it provides the benefit that we think it should provide. Still a lot to learn, dozens of trials. All we learn is that we need to learn more.
Absolutely. I think those would be the parting comments, actually. Yeah. Otherwise, we can go on the entire night over here discussing on different aspects of diabetes. I think it's wonderful. Thank you very much, Dr. John Buse. And of course, thank you, Rajeev Chawla, Dr. Shehla Shaikh, for providing the local sort of flavor. And of course, our participants for taking interest and asking these questions. And sorry, we couldn't take all of them, but I think we have covered the most important ones. So it's back to Altaf, is it?
Yes. So on behalf of Acumentis and our division Noveltis, thank you. I must sincerely thank all my esteemed faculties for participating in ADA Konnect program. I individually express my sincere gratitude to Dr. Subhankar Chowdhury, Dr. Rajeev Chawla, Dr. Shehla Shaikh, and Dr. John Buse. My gratitude goes to each and every delegate who has joined this finale of ADA Konnect. There are about 692 doctors across the country in India who joined this program. And my sincere thanks to my CEO, my management team at Acumentis, and all my colleagues from both sales and marketing teams who have made this program a very, very grand success and possible. So I sincerely thank you so much. Thank you so much. Thank you so much.
Thank you. Good night.
Thank you.
Good night.
Stay safe.
Stay well.
Have a good weekend.
Stay safe.
Stay safe.
Thank you. Bye-bye. Bye-bye. Bye-bye.
Bye.
Yeah.